So I would like to welcome one of our esteemed board members who is going to do our formal opening for this evening. And could I please ask James Gray to come forward and do a formal opening for us. Thank you, James.
E ngā manuhiri, tēnā koutou. Nau mai haere mai ki AMRF Lecture Series 2. Whakatau mai ki runga i a mātou. He mihi tēnei ki ngā kai tautoko o tēnei kaupapa ko AUT University, ko Auckland University, me JMI Wealth, kia ora koutou katoa. Ngā mihi nui ki ngā kai kōrero o te pō, Dr Rosemary Frey, Associate Professor Gary Cheong, me Professor John Windsor, nau mai. Ka huri atu te mihi ki a AMRF. Ngā kai whakahaere tēnei hui mō te rātou manaaki me te tautoko. Kei te mihi tuatahi te mātou nui o te rangi nāna ngei mea kātua. Tēnei te mihi ki a koutou. Ka nui te koa me te hari ki tūtaki i a koutou i te kaupapa. Nō reira, ngā mihi nui ki a koutou, tēnā koutou, tēnā koutou, tēnā koutou katoa. For those who don't know me, yes, I'm a trustee on the Auckland Medical Research Foundation. My name is James Gray, and on behalf of AMRF staff and the board, I'd like to welcome you all here this evening for our second lecture of the series. I'd also like to thank some of our sponsors, AUT, Auckland University and JMI Wealth. Small caveat, I also work for JMI Wealth. But thank you for their support. We'd also like to welcome our speakers tonight, Dr Rosemary Frey, Associate Professor Gary Cheong and Professor John Windsor. Welcome to our lecture tonight. Also like to thank AMRF, our staff, for putting this together tonight. Looking forward to hearing hearing the speakers tonight, and as you are all here in person and online as well. So yeah, I'd just like to welcome everyone here tonight, and I hope you enjoy this evening. Thank you.
Well, thank you, James, for such a wonderful wonderful welcome and introduction. And I'd also like to warmly welcome you all here tonight. Thank you for coming out on a chilly night, braving the traffic. At least it's a lovely, fine night, so I'm glad you could all find your way here. So, as I introduced myself before, Sue Brewster, Executive Director of Auckland Medical Research Foundation, and this is the second in our 70th anniversary celebration speaker series. So, and we're also here tonight celebrating the awarding over $100 million of medical research funding. So there's a lot to celebrate. Like James, I would like to thank our 70th anniversary partners, who are JMI Wealth, represented by James Gray here tonight. I'd also like to thank the Auckland University of Technology, represented here by Brett Cohen, and also the University of Auckland, and we have Mark here tonight representing as well in place of Frank Bloomfield. So thank you to your partners. You've made a lot possible to happen this year, and you are the ones also for AUT and for UOA doing the research, so that's fantastic. And obviously JMI Wealth are helping us bring in the dollars. So Dr Rosemary Frey is a Senior Research Fellow in Nursing at the University of Auckland and has a PhD in Sociology and Social Psychology. Rosemary's research is focused on palliative care and more specifically end-of-life care. Rosemary has generated a significant body of evidence which challenges dominant paradigms informing end-of-life care practice and policy, particularly within the aged care residential sector. Her work and findings seek to empower teams delivering the service with the knowledge and confidence needed to deliver a quality palliative care experience. So obviously with both topics, being palliative care and assisted dying, there can be some sensitive material in these presentations, so I just wanted to make you all aware of that, and hopefully you all came expecting these topics to be covered. So I think we're ready for Dr Rosemary Frey to come and take the floor and talk to you all about palliative care.
Tēnā koutou katoa, ko Washington te maunga, ko Charles te awa, ko Massachusetts te rohe, I tupu aka e ho Boston, ke te kowhira ho e noa nai ko Rosemary Frey toku inwa. I'm just going to cover a little bit of some of the work that I've been doing briefly. Who I am, my research projects for the past 10 years have tended to focus on palliative care and end of life, particularly for underserved groups, including older people. That's been my work. These are some of the recent grants that I've been involved with, the AMRF Experiences of the End of Life Choices Act, that Dr. Gary Chung will talk to you about in more detail. And the other two projects on which to touch on deal with hospice care delivery after COVID. So what kind of innovations were developed during lockdowns that actually have uses now? And the second project I want to talk about a little bit is looking at telehealth for underserved populations. How can we reach more people with telehealth? Those are the two projects that I'm going to talk briefly about. So the first project, hospice care delivery for patients with life-limiting illness post-COVID-19, I conducted with Dr. Tess Mawiki-Maxwell, Ms. Jenny Thurston, Jackie Robinson, Dr. Deborah Raphael, Dr. Lisa Williams, and Professor Marion Gott. All except Ms. Jenny Thurston are from the School of Nursing. Jenny Thurston is from Mercy Hospice. Okay, everybody knows what happened during lockdown. Services were crawled back. People couldn't have access to things. But that's only half of the story. What people had to develop new and innovative ways of delivering healthcare. And so that's what I wanted to explore. What innovations did people come up with to help serve the community that in a way that was new? So that was the aim of the project. It was a two-phase project. We used transdisciplinary action research and a partnership approach. So it's working with people rather than looking at people as subjects was the idea. In part one, we used a telephone survey, which was either telephone, video, or in-person survey. And we sampled areas where during COVID there was a high incidence of COVID. So more than 25 cases per 100,000 was where we were looking at locations to talk to healthcare providers. We looked at hospices, we looked at community groups, hospitals, organizations that worked with hospice. The idea was to get a picture of what they all did during COVID. That was phase one. And in phase two, we recalled some of the participants from the first part of the study and asked them to talk specifically about their innovations. What things did they develop? How well did they work? Are they still using them? We had two different, what we called Think Aloud sessions. The first one was stakeholders from the various reference groups. And the second one focused specifically on Maori needs, palliative care needs, and Maori health professionals, which those sessions were guided by Dr. Tess Mawiki-Maxwell. So we used a short questionnaire because people are time sensitive and they don't have much time, and we had open-ended questions. We used both inductive and deductive analysis, guided by the questions we asked. Phase 2 is also a thematic analysis. And in that phase, we categorized the recommendations that people came up with. So these are these were the themes from phase 1. The 3 broad categories dealt with competence, relationships, and then indigenous activation. There was a lot, I'll go through them briefly, the sub-themes. So, telehealth existed before COVID. It's just that people didn't want to use telehealth before COVID. They didn't have to, so they weren't going to. But what they found, what people found was once they actually got into using it, that it actually was a useful service to have. And so they've continued on with it. And what they've found as well is that not only did they feel more comfortable with it, but it actually met some patient needs. Having to come in to visit a health professional was not always easy to do. So having the option of telehealth was better for some people, and that they didn't realize it before. Policies, there was a lot of information around policies, particularly visitor policies. There were lots of rigid restrictions when COVID first hit, and what the hospices and aged care facilities found was that rigid enforcement of those policies led to lots of problems in terms of grief that hadn't been dealt with. And so what they realized is that they had to change how they did their policies. I have a quote from one of the hospital physicians as to their way of looking forward. We can stop the disease getting in, but we don't want to lose our compassion. So it started to be a more flexible way of looking at how you do policy to meet people's needs. Education in terms of COVID lockdown, particularly in aged care, they found there was a lot of gaps in terms of what nurses on the floor, what their knowledge was, and they found they needed to address it. But it has led to a lot of upskilling in terms of what people are now able to do. Community. New relationships got formed, or relationships were there but were strengthened. And there were other situations where people, there was damage to some relationships because hospice, for example, decided to close their doors and they weren't going out and doing community visits. And so it fell on the district nurses. So there's a building of fences that's still going on right now. Lockdown also had an impact on team cohesion. Prior to COVID, people just, were sort of siloed and did their jobs. During COVID, this one particular example, they talked about how they had Zoom huddles to see how everyone was getting on. And they continued these huddles after COVID, not in a virtual way, but they checked in with each other. And it strengthened the relationship in the organization. In terms of indigenous activation, the first comment has to deal with the fact that there was a barrier that Maori health professionals found in terms of dealing with the community. Having the mask and the PPE created a barrier in terms of establishing a relationship. So what they had to do was they would stand at the door, show her who they were before going in so that they could connect with the person, which was really important. The second factor that happened was that care wasn't just limited to health provision. It was wraparound care. It was a holistic idea of how you provide care to your community. And that sort of has continued as well. And the third factor that arose out of COVID was that caregivers at home realized that they could do things. There was a sense of empowerment in their own abilities to deal with taking care of a loved one that they didn't have before, as the quote is showing. Okay, phase 2, I just talked about some of the tools that we developed. DocSeeMe is actually pronounced DocSeeMe, and it's basically a telehealth tool. Has a lot of wonderful features. It was developed in the US, and it's a secure platform from which to have visits, GP visits. This was provided by a GP. New policies got developed, linkages between, in this case, a hospital and the what was DHB at the time, such as a repatriation policy. Interestingly, there was new thinking in terms of a GP practice, where during COVID they had a red zone, and the GP talked about how there actually should have been this sort of arrangement in the first place, because I have older clients who have various health issues, maybe some of them are immunosuppressed. I should have a separation. I shouldn't have everybody in the same waiting room. So that has been continued as well. The final comment here has to do with communication. They realized that too many people were contacting people at home, and there needed to be a streamlining from the multidisciplinary team as to who is contacting the caregiver at home, so there's not an assault of information going to the person at home. Okay, so the recommendations basically have to do with keeping going with exploring digital health, being flexible with visitor policies, continuing exploring more relationships, interdisciplinary relationships, keeping up the team cohesion, and one of the key things was more embedding of palliative care within the aged care sector. It's in some places, but not all. For Indigenous activation, more connection with the families. What was spoken about was the fact that while there are resources on a hospice website, they're all over the place. It needs to be collated in one place so that it's easily accessible. Access to the well-being of there has to be more connection to the family at home as well. More collaboration, particularly with Maori communities. They felt that everyone was sort of doing their own thing, and there needs to be a more general plan that gets everybody in the loop. And they came up with the idea of that maybe there should be like a civil defense plan that included hospice as well. So that was my general conclusion from that project, not to forget the things that were so hardly learned. My second project, briefly speaking about, has to do with underserved communities. This is a Catalyst Fund grant. I'm collaborating with Associate Professor Aileen Collier at the University of Flinders, and Matthew Alsop, Dr. Matthew Alsop from the University of Leeds, and Dr. Sarah Mitchell, who's the National Clinical Director for the NHS. The goal of this is to basically see what's out there, what telehealth services exist, and is there a way that we could adapt any of them to here that would be useful for underserved communities here? So year one, so last year in 2024, we went to visit 6 organizations in the UK. This coming year in September, we're going to be doing site visits in Adelaide, Australia, bringing together Australian elders. They have a reference group, and Kaumatua from the Rawaawa Community Trust here, and bringing them together in Adelaide to discuss access issues for telehealth for both of those groups. So there were 6 organizations that we visited. I have a list of them somewhere. I won't go into it. Basically a telehealth hub. We went to 2 hospices and looked at what they're doing in terms of telehealth services. One of them is a teaching hospice, one of the few teaching hospices in the world that not only does the services but also does research. And we went to a national patient advocacy group called Compassion for Dying and support organization. I'm not going to go through all of these. These are just some of the projects that they had going on, just some of them. ECHO is basically for physicians and health professionals. It's a knowledge sharing service, originally developed, I think, in the US. Breeze is a patient service for people with chronic respiratory conditions. It's a series of videos. It gives some coping strategies. I talked about Compassion for Dying. It supports individuals in terms of information. They do legal services in terms of filling out documents. They do advocacy as well for underserved communities. They particularly work with ethnic and minority communities, getting them information about end-of-life materials. Gold Line is a 24/7 telehealth service developed in Leeds. It's one of a suite of programs. They have one for aged care. They have one for just people with chronic conditions as well. They have a service for prisons as well. So this is one of the services. We heard a presentation by Dr. Mitchell on, they have a data set that looks at major conditions and hospitalizations, place of death and demographic characteristics. What it showed that 50%, fewer than 50% of the people who die are on any kind of end-of-life register, which I found fairly interesting. Again, more services that have to do telehealth services. Marymount Hospice, and I'll talk about in a little bit more detail. Compal is an AI-driven service for people with dementia, which is an interesting service. I'll talk a little bit about Goal Line, the 24/7 service. It's headed by Dr. Linda Wilson. Gold Line was launched in 2013 in Leeds and Bradford. To be eligible for it, you have to be registered with a GP, and you have to meet the criteria, the prognostic criteria for the gold standards framework. What's good about it is it gives you connection to patient records and ensuring they're up to date. It's integrated with the local health network, which is really good, and it provides resources for patients. Challenges still in terms of there are some areas where it does not reach. Underserved communities still do not have access. Funding is an issue. They have, at the moment, they have a public-private partnership going on. So there are different goals depending on, that is a problem. It's the only scheme around in the UK at the moment, so there's no way to compare it with other services to see how well they're actually doing. Marymount Hospice is one of the hospices we visited. These are Aileen is second to on the left there, followed by Matthew, and I'm way down there on the end there. These are just some of the services that they offer. They offer virtual consultations, symptom management, psychosocial support. They even have telehealth. Physio is included as one of their services. One of the problems they have is that it doesn't reach everywhere. The area that they covered includes islands off the coast, and the telehealth does not reach there. So there are in-person visits that have to be done. And in fact, they do in-person visits with everyone before they sign up for the telehealth. Those who can reach it still have to have an in-person visit first before they follow up. Okay, so the telehealth applications are great. Yeah. The models like Gold Line have a lot of potential, but there's still practical issues in terms of how you include everyone There's still people who aren't being reached. As I said, there's trouble between the public-private partnership. They have different agendas, right? It's great that there's increasing research attention on understanding engagement with telehealth systems. There's lots more research than there used to be. There's research into patient safety in low resource settings that's just starting to grow. And a focus on engagement in low resource settings, which is just starting to pick up now. So where we go from here. So the next stage, we're going, as I said, we're going over to Adelaide to do the consultations between the kaumātua and the elders. And that will be followed up in the year after with a hui in Hamilton at Rawaawa Community Trust, reciprocal to see more exchange of ideas. The ultimate goal is to come up with some kind of proposal as to a test intervention telehealth service that we can apply for funding for. So that's our goal. Before I leave, I just wanted to thank all my colleagues who have been involved in all the research that I've done, Gary as well, Professor Marangott and the TRI Palliative Care Research Group, my head of school, Dr. Julius Lark, and all the people who've kindly given their time to be a part of the research. I wouldn't be anywhere without them. Thank you so much.
Rosemary up here, we might do, because it's fresh in everyone's mind, we might just do a few questions now.
Oh, okay.
Yeah, rather than go straight into Gary. So one of our runners is running.
Oh, run.
Any questions? Can I get you? Yeah. I've got a question, Rosemary.
Okay.
What is your biggest concern for palliative care in New Zealand at the moment?
Only one.
Only one. How many concerns do you have?
Access issues for underserved communities is one of my biggest ones at the moment. Yeah, getting palliative care incorporated into more aged care facilities. It's in some, particularly in Auckland, but not everywhere. That's another one of my concerns as well. I think those are the two top ones. Yeah, just having people have access, and just information is lacking, I think.
And so your research aims to, I guess, provide services and things that are going to help with that access?
Well, at least find ways to help clinicians be able to get the information out to people. Yeah, if I can't do it directly, do it through them so they have the information to be able to deliver it. Yeah.
Thank you. I'm just interested in any thoughts you might have about integrating AI, artificial intelligence, with the research work you're doing and the effectiveness of AI in on-the-ground work.
Well, as one of the projects, actually a couple of the projects up there are integrating AI, and I'd like to see what the outcomes of those research projects are to see how well it could be adapted to here. There are a couple of big projects. I think that the European Union is funding one of them. I'd like to see what their outcomes are to see how applicable it would be to here.
Thank you very much, Rosemary. Yep, wonderful. Yep.
Okay.